Okay, great. That's exactly how I wanted it to look. Okay, so we're going to look at the shoulder joint, and what we'll start off with is a bit of an anatomy review. So we'll look at the bones and then the layers of muscles, and then we'll look at the arm lines, and that should, just sort of give us some context. Okay, so I'm going to move this over here. So yeah, here's the bones of the shoulder and the arm. I like these images from Trail Guide. This is Trail Guide to the Body. And if you ever were thinking about buying, a book for anatomy, this is a really great book. This is, I don't know, it's probably on its 7th or 8th edition. But what it does is it breaks up the body into sort of joint areas, and then it will show you the bony anatomy, the muscle anatomy, and then it teaches you how to find it by palpation. So this is like a book that we use as teaching massage students, so they can find all of these structures and muscles on their own body, and then on subsequent bodies, because that's what they'll be working on. So I think that's a very practical way of learning anatomy, rather than just learning it as a concept that remains in your mind. It's kind of nice to get in there with your hands. So we'll do that a little bit today. So let's look, if one of the things you should notice right away, even with an untrained eye, is that the arm and the shoulder blade and this bone here, a lot of people call it the collarbone, but it's the clavicle. Like none of this seems to be attached. It's attached right here at the this is the sternum here, sternoclavicular joint. So this little joint right here, this is actually a little synovial joint. So that means it has the characteristics of a synovial joint, where it would have, cartilage coverings on the joint surfaces and synovial membranes and a joint capsule and all of that. Because if you just do some arm movement with me right now, so see if you can find that joint. So look for there should be a little notch right here in the middle. We're not seeing much of a notch here. It's really kind of formed by the tendons of the sternocleidomastoid. So those big tendons, and so go right into that. And then go to the right or left and put your fingers there, just kind of fingers like this. And then move your arm up and down. You'll see that this bone here, the clavicle, is going to move up and down. And the point where it attaches to the breastbone, the sternum, is where that movement is happening, at that sternoclavicular joint. Okay, so that's how your arms are attached to your body. Other than that, it's all soft tissue attachment. Like the joint capsule and the fascia and the muscles and tendons and ligaments and all of that stuff. There's no other bony attachment. So that's pretty interesting to note. And that's, partly why we have like such an incredible range of motion with our arms. It's really the shoulders and arms enable us to do pretty expansive movement. And some of the key movements that humans can do are things like climbing, So that enables us to do a climbing action. And, we wrap our arms around things. We pull ourselves up on things, we drag things along the ground, when I say we, I mean, humans in general, maybe not us so much, but when we have the opportunity to do so, definitely you should go for it. Okay, so then we'll follow this collarbone, the clavicle, out to where it meets the shoulder blade. Now, the shoulder blade is already a very interesting bone. So it's got, we think of it as the blade. So this is the blade part. This is the underside we're looking at, okay, the side that goes up against your rib cage, so like we see over here. And it has a depression, a fossa, so there's like a shallowness there, and then bony ridges around. And what we're looking at here are two kind of protrusions that come off of that shoulder blade. So you know, again, the way you experience it in your body might not even seem like that at all. So let's just see if we can feel these. So let's start with following the clavicle out to the acromion. This here is called the acromion process. It's a process because it sticks out. And so like where that meets, so if you can follow your clavicle all the way over, you'll probably feel a bit of a bump here. There's oftentimes a bit of a bump. I have quite a decent bump here myself. And then again, you could put your 2 fingers like so on that point and raise and lower your arm. Not enough to lift the whole clavicle up like we did before, but just abduct. So that means move this joint into abduction. So it would go out here. And you should be able to feel that there's some movement, because in order for your arm to abduct, so do you see what I'm doing? To abduct, this shoulder blade has to allow it. So it has to be able to move on the rib cage, the thorax, to allow that movement. And then beyond there, it has to move quite a lot. So this shoulder blade has to go with you. If you try to pin your shoulder blade down and lift your arm, you're only going to be able to move the humerus bone a few degrees. Any more beyond around 45 degrees, 35, 45 degrees, it's going to have to slide so that your arm can lift up. Does that make sense, you guys? Can you feel that? Are you doing it? Yeah, you got to do it. So yeah, just feeling right there, fingers on the end of the clavicle and the acromion. And there's going to be, this is going to, what they call that upward rotation. So when your arm is going upward, it's upwardly rotating. Now, conversely, if you brought your hand behind you and laced your fingers behind you, then the shoulder blade would have to downwardly rotate to allow that movement to happen. Otherwise, yeah, again, if your shoulder blade was stuck to your back and you couldn't move it, then your arm would not be able to move into adduction, that's adduction, behind you. Are you guys familiar with these words? So abduction would be taking away from the midline, and adduction is moving toward the midline. Okay, good. Okay, so there's the acromion. Okay, let's see if we can find the coracoid process. Okay, and I don't know why that's not labeled, but this process, the sticky outy thing, that you can feel that in the front of your body. So if you go off of your clavicle, so find sort of toward the end of the clavicle, drop down, and I also landmark with the actual ball of my shoulder joint. So I come in from there, and then see if you can feel, there's usually like a bony protuberance. And it's very close to, look at how close it is to the shoulder joint. So don't be over here in the middle somewhere. You have to be over pretty close to the shoulder joint. So you feel the ball, and then just move inside of that, stay under the clavicle, and you can often find a bony sticky outy. Now, if you're not sure you're on it, move your shoulder forward into your fingers. And if it feels like it's separate from this ball, then you are on the coracoid process. That's a very important little bony protuberance. Okay. All right, so that's the coracoid process. So on the socket, we're going to look at a dissection of the socket in a minute. But you'll see that the shoulder socket, this is a ball and socket joint, but that socket is about the size of a teaspoon. You know, like it's literally about the size of a teaspoon. It relies on extensions of connective tissue, and then the rotator cuff tendons and ligaments and joint capsule in order to keep the shoulder joint seated in the socket. So again, it just all points to this being a joint that's really about mobility, which is why we have to actually really work on being able to stabilize it. Okay, and then, so we have lots of other images to look at. And then here is the humerus bone, right? The upper arm bone. And you'll see there's a groove right here. This is your biceps tendon groove. We'll feel that in a moment. I think it'll be easier for you to find when you look at some other images. Okay, so that's basically your shoulder girdle, which would be the clavicle, the scapula, and the humerus. Any questions about that? Good. All right, let's look at some muscles then. So what we have here, just so you know what you're looking at, is the back of the body. That's pretty obvious. On this side, you see where it says superficial? That's muscles that are right under the skin. The other half of this image are the deep muscles. So they have other layers of muscles on top of them. Okay, so if we peel these muscles off, we would find these other ones on the deep side. Okay, so when we look at these muscles, the reason why we're looking at these particular muscles is because they move the shoulder. Okay, they move the shoulder joint. Let's talk about the movements of the shoulder joint really quickly. Does anybody want to tell me what they are?
There's abduction, adduction,
Can you
circumduction.
demonstrate quickly?
Oh yeah. Abduction, adduction, circumduction. Right?
Circumduction
Or
is
is
not
circumduction this?
no. Circumduction is it's not considered a range of motion exactly. It's just something that the shoulder can do. Okay, so when we talk about the range of motion of a joint, we mean on the cardinal planes, basically. So abduction and adduction happen on the frontal plane, and then we have sagittal plane movements.
Flexion and extension.
Yeah, flexion, extension.
But then what do you call that ability to rotate in the joint like that?
You just said it.
Rotation.
So we would have internal rotation and external rotation. Right. And then sometimes we'll call like action on this plane, on the horizontal plane or the transverse plane. We would call it horizontal or transverse adduction and abduction. Then circumduction would be like a combination of all of those things, right? Because like, well, right now we're in flexion, and now we're kind of in abduction and extension, and now we're internally rotating again. You know what I mean? So you're going through a whole bunch of different actions as you move that joint in a circle, or move the arm in a circle, basically. So that's why it's not a specific range of motion. If we were to test the joint for what it could do, we would use like the cardinal planes, and we would use the basic actions of the arm. Okay, so that's why we're looking at these muscles, because those muscles move the shoulder joint. So the first muscle to look at is the most superficial one, and that would be your trapezius. So your trapezius, you can feel on yourself. Let's feel it from the back of the head. So you feel like, you know, the bump of your head, and under that, that's your suboccipital area. So the trapezius would go down, straight down the back, and the fascia of the trapezius is all along all of the spine, the cervical spinous processes into the thoracic spinous processes, all the way down to T12. Okay. So all along here is basically its fascia. It almost looks like an aponeurosis, like we see down here, the thoracolumbar aponeurosis. When you see white stuff on this image, it's fascia and like dense areas of fascia. So all the way down the spine, this is the trapezius, this is its origin. And then it sort of makes this triangular shape. So part of it is, again, superficial, and it goes, if you can feel into your neck and onto what you'll come into, you know, the bones we were just feeling. But this here, what you're looking at here, is called the spine of the scapula. So that is a ridge on the back of the shoulder blade, and the trapezius comes right down and attaches along that spine, it's called. So, you know, it's It's actually depends on the person, but it is a thinner muscle. There's lots of muscles underneath it, just so you're aware. But these are muscles that lift the scapula up, right? So if you see people doing this a lot of the times, they might have a very overactive upper trapezius. And this is one of those muscles where, man, I could go into this in so much detail. I'm going to try to rein myself in a little bit. If you guys have questions and you want me to go deeper, you just let me know. But I don't want to make this a 4-hour presentation. So I have to, yeah, I'm going to try and pull back just slightly. Okay. So upper trapezius does different actions than lower trapezius. Our lower trapezius helps us move the scapula down, so if you're using a cue in yoga where people have their arms overhead in flexion, and you see that people, their whole shoulder girdle, so now that's clavicle and the scapulae and the head of the humerus, they're all up around their ears, and you want them to like, okay, let's relax your neck muscles, and we'll use the trapezius and some of the other muscles we'll look at to help, stabilize our shoulder position. You're asking them to drop the shoulders down and activate their lower trapezius is one of the muscles that would be active. So you would feel that in your upper back. You just feel, okay, yeah, now I feel some engagement here that is helping me not pull my shoulder girdle up around my ears, okay? Now, I'm not telling you to use that cue or anything, but that's generally what they're trying to achieve with that. Okay, so we'll keep going. Now everybody can feel their deltoid. The deltoid is sort of the shoulder cap muscle. So this is, again, it's superficial. It's just under the skin. It's actually three-headed. So you have like a rear head, a medial head, and an anterior head. And this, we're going to look at it, the type of muscle that it is and everything, but it's the deltoid helps us when our movements become a bit stronger. It doesn't generally initiate movement to the same degree as some of the other muscles we're going to look at that are deeper. Okay, so the deltoid is sort of like the glutes of the hip, the gluteals. Okay, gluteals have anterior, medial, and posterior fibers. They're also phasic muscles. They're also like responsible for stronger movement. So that's kind of what the deltoid is like in the shoulder. You don't usually hear, unless you're in like extreme bodybuilding and stuff like that, you don't usually hear people injuring their deltoid in yoga. It's usually the deeper structures that get injured. So just again, so you're aware. And then under that, we're going to have a couple areas that we'll actually be able to see better on the other side. So I'll leave it at that. But we do want to look at this muscle here. This is latissimus dorsi. So this muscle, which is down on the back, actually moves the shoulder because it attaches to, I'll show you where it attaches. It attaches to this ridge right here on your humerus. So it comes from underneath around your back, and its tendons come up here. So it actually is a shoulder mover, and it internally rotates the shoulder, pulls the shoulder behind you as well. So if you were like rowing a boat or something, you would be using your latissimus dorsi for sure. Now, some of these muscles are, well, this is the major internal rotator. We're going to look at others that internally rotate. These tend to be pretty strong muscles, which is why when we use organization and activation, we fire up the external rotators. So we have a better balance of strength and stability for the joint. So we're going to go into the deeper muscles now, unless anybody has a question. We're doing all right? Okay. All right. So now let's look at one of the potential muscles that might be bothering Jane today. This is the rhomboids. Okay. So you can see like it's called the rhomboids because it kind of looks like a very geometric shape. It's kind of got straight edges. And so it's it moves the shoulder blade and stabilizes the shoulder blade. Okay, and that is a big, as you saw, a big part of shoulder movement. Okay, so we actually want to use the rhomboids when we organize and activate, and you'll see that it's, you know, it's part of the arm lines and all of that. So we're definitely firing that up. This this muscle is really interesting. Like, you can use it to pull your shoulder blades toward each other, so protraction. And when you retract, you separate your shoulder blades from each other. You abduct your shoulder blades, so you could call that protraction. They elongate a lot. It's pretty crazy. And these can be quite weak on people who have like a more collapsed thoracic position or head forward posture. They can be quite weak, but we need to make sure those are very strong. They sort of indirectly help us maintain upright posture. And you're going to see, like down here, we have the erector spinae group. We won't look at that too specifically today, but again, just so you're aware of what lies beneath there. Okay, other muscles that move the shoulder. Now we're getting more specific to the shoulder joint itself, and that would be supraspinatus. So we've got supraspinatus, infraspinatus, teres minor, and teres major. This, well, not teres major. We have subscapularis, which you can't see in this image. So supraspinatus, teres minor, infraspinatus, and subscapularis, which we can't see. Those are the four muscles that are the rotator cuff muscles. So you can see that, well, maybe you won't remember, so I'm going to take you back. Do you see how on the shoulder blade, there's like this gap between this acromion and the head of the humerus? So you have this supraspinatus muscle that comes through that gap and grabs on to the head of the humerus. And then you've got the other muscles, the infraspinatus and teres minor, that grab on a little more toward the back edge of the head of the humerus. So here's supraspinatus. It lives in that little top area of the scapula and then slides under the acromion. That's the acromion right here, and attaches to the top of the humerus right there. So all of these, and it looks in this picture like, you know, the tendons stop right there, but they go right into the joint capsule. So they flow right into the joint capsule. And then what you're looking at here is the long head of the triceps, which also attaches to the close to the head of the humerus bone as well. Actually, this is the short head on the outside, and this is the long head. Now, the long head goes under these muscles to attach to the scapula as well. And I'll show you right where it attaches. It attaches to this little area right here. So one of your heads of your triceps attaches to the scapula. The other one attaches to the shorter heads, attached either just to the back of the humerus or up a little bit higher, like, well, it is on the humerus. One head goes up a little higher, the other one is a little deeper, but all three heads all three heads converge into the same common tendon, but they have two attachments to the humerus and one to the scapula. Okay, that I hope sounds somewhat clear. Okay, you guys want to feel, let's try and feel our rotator cuff. Okay, so we're going to take our fingers into the shoulder blade here. And remember, these rotate the humerus bone. So I recommend rotating your humerus, and you'll probably feel some action under your fingers. Now then, your supraspinatus is going to be, can you guys feel like this blade of your shoulder blade? This sort of spine, that's the spine. So if you sink your fingers just above the spine and lift your arm out to the side just a little, you should feel that muscle wake up. You really have to sink your fingers in, because trapezius is on top. So in order for you to feel supraspinatus, you have to sink in a little bit deeper. Okay. So those are, and then you have subscapularis. So subscapularis, here is what I recommend. Take your thumb, go into your armpit, go into go deep into your armpit. And the way to get deep is bring your arm forward, leave your thumb in there. As your arm comes forward, your shoulder blade is going to slide forward. And then if you rub with your thumb, you're probably going to feel some tenderness. You might even be on a nerve there, but it does usually feel, subscapularis almost always feels tender. So, you know, if you can see where I am, there's my thumb. I'm pushing into the back. And these are quite, you know, meaty muscles, especially this one that's not included in the rotator cuff. This is the teres major. This is called Lat's little helper. So latissimus dorsi and teres major, they always act together. They have the same insertion point, different origin, but they flow into the same insertion on the humerus.
So I thought there were 4 pieces to the rotator cuff: is supraspinatus, infraspinatus, and teres minor, not teres major.
Right. And subscapularis. That's the one that's underneath. Yeah. Yeah. I think we do have a good view of that in a little bit here.
Okay.
So we're going to have, we're going to look at the muscles on the front, and then we're going to get really specific to the shoulder joint itself, because that's kind of the stuff we need to know. Okay, so now we'll look from the front side, and same thing on this image. We have superficial over on this side and deeper on the other side. Okay, so you can see your trapezius, which we felt before. It actually wraps around the front to some degree, meets up with your clavicle, and then flows into the deltoid. So again, the deltoid is, you have 3 heads, right? So this is the anterior head that we're looking at now. Everybody knows their pecs, right? Their pectorals. What you might be, what the pecs do is adduct. They're pushing muscles. If you push your hand forward, you know, so that's sort of adduction on the horizontal plane, you're going to feel those muscles really jump up. You could think of them as like your push-up muscles, your grasping muscles. But deep to them is called the pectoralis minor. So let's see if we can find this. It's originating on that coracoid process that we felt earlier. We'll take you back there briefly. This coracoid process, this little sticky outie. So see if you can find that again. And then if you move down just a little bit and a little bit diagonally toward the center of your body, and you give those muscles a little scrub, oh, they're always so tender. Again, some of these deep muscles are tender because they're postural muscles, which mean they get recruited all the time, especially when you're doing repetitive tasks. So yeah, so pec minor and pec minor, this, a lot of our postural muscles have a tendency to be like grippers, you know, when we're under a lot of stress, or when we've been like over recruiting certain muscles. These are ones that tend to be over recruited. They can sort of, they want to tighten down, and they'll be like innervated like by the nervous system to like tighten down. And it can really pull the shoulder blade forward, you know, that sort of anterior caved in kind of look. This might be one of the muscles that would pull you in that direction. And again, it wouldn't mean that it was strong necessarily, but it's really under duress basically when it's doing that. What else can we look at here? Well, the biceps break guy. Oh, go ahead.
Another way that I've accessed pec minor is
yeah, under.
You grab the chicken wing, like you grab your pec.
Yeah.
Then wherever your thumb is, like, so this is like the pec major, and you go underneath. So you're kind of like this. And then wherever your thumb is, you can kind of dig in, and that you can get to pec minor if you kind of push that way, if you can relax it.
Oh yeah, you have to go pretty far.
You have to go pretty far. So some people can't even like get there under.
Yeah.
their thumbs under like that. So if you do go that way, but that's just another way, because then you could even like go like that.
Oh, I see what you're saying. Yeah.
Just another way I've accessed it.
Yeah. Even just like scrubbing across it can give you quite a lot of relief, especially if your shoulders are feeling really bound up or whatever. And, you know, if you just try that, you actually feel like, oh, wow, that feels so much better. I think I must use those as I'm hunching over my computer. So yeah, awesome. Okay, so then we also have biceps brachii. So a lot of people don't know biceps brachii. They always think that the biceps are the bulky muscles. Biceps brachii is not actually a bulky muscle. It's the brachialis that lies underneath it that's bulky. This one here crosses two joints, and it flexes the elbow, also supinates the forearm. And then it flows up in front of the shoulder. So we will see its tendon because it's very significant for us as yogis. So this one, it comes up in front, it goes under these deltoid muscles and attaches to goes through the humerus, attaches to the top of the glenoid cavity, and also attaches to that coracoid process that we were just feeling that pec minor attaches to. So we'll see this again in a moment, and that will get you oriented. So just kind of going in by degrees. All right, now this is a really close-up look at the joint capsule itself. So here, Dina, is your subscapularis muscle. So just so you know, you're looking from the front of the body. You've had deltoids and everything all removed, pec removed. Even the thorax, we don't see the thorax here. We're just seeing the underside of the shoulder blade, the scapula, and that is subscapularis. You see it's named for its location, right? Subscapularis. Great. So its tendon, this is its tendon, also just flows into the joint capsule. All of these tendons do. And now let's just go above. So we've got, it just says rotator cuff tendons. This, though, is your supraspinatus. Remember I was saying, like, you feel it from the spine of the scapula. It's in the fossa. It comes under the acromion and attaches to the head of the humerus. And the reason it's important to know this one is because that's the one that is much, much more commonly injured, is the supraspinatus tendon. Almost every time you hear about somebody with a rotator cuff tear, that's what it's going to be. By far the most common. Now, if you had an injury where somebody had a blow from the front body and their arm went back like this, then they could have a subscapularis tear, but usually it's going to be supraspinatus. So I think, Dina, you had an interest in this joint right here.
Well, I'm interested in the whole, I have students with shoulder pain, and I don't know, even through organization and activation, even though I'm teaching that, and I say throughout class, you know, dial out your hands. Are you feeling, I always say, do you feel the lats turn on? Because I know if they can turn their lats on, they're dialed out.
Because the lats don't externally rotate.
But when I dial my hands out, I feel connection to my core here. Is that not the lats?
No.
What am I feeling?
It would be, let's go back. It would be the rotator cuff. It'd be infraspinatus, teres minor, rhomboids, serratus, which, you know, you can't see here either. Can we see it on the next one? Serratus anterior. This one here is really flowing into the core. Yeah. So that would be under the lats.
I feel here. I dial out.
Yeah. Yeah.
That's
serratus anterior.
Serratus. That's good to know. Okay. So I've been saying it wrong to my students.
Now, if you were doing dial out and spread your hands apart, you could get some latissimus dorsi, but the simple dial out is not going to activate lats.
Okay.
It will now if you are in, like, if you're If you're moving your arm into an extension, your lats would do that. But say like if you're in plank or something like that, that's not the lat doing that.
Okay.
Again, like if your arm is overhead and say, say when you're, okay, here's where you could activate your lats. In downward facing dog, dial your hands away from each other, and then you like kind of pull back. Like, so lats are pulling muscles. So anytime you're pulling, you could like have hands overhead, pull on the strap or whatever, you're going to definitely activate your lats. Arms overhead with the strap, anything like that, pulling.
Okay.
Yeah, but simply dialing out is not really going to fire up the lats.
So when you dial up and you lower, well, if you're not dialed out and you lower in Chaturanga and we typically see a student kind of collapse this way. Are you pulling on that acromioclavicular ligament? Like, is that where you
I would really have to see that. If say we're collapsing this way, you see how my
No, we're collapsing here. We're lowering to Chaturanga and the chest is leading and
the
you're
chest
dumping.
is leading. So
Yeah.
we're doing it properly.
No, you're doing it improperly. You're completely dumped into your shoulders.
Oh,
Like,
okay. Okay.
like, yeah.
Yeah. Okay. It's hard to say because that would really depend on the angle,
Mm-hmm.
you know, and whatever else they had active, you know, like actively you can put a joint through a range of motion and it comes through that unscathed. Passively, or like doing an action that you don't have control of, is just a different animal, right? So you're always dealing with, like, because there's this downward force that our weight will create, we're always have to look at like what angle are like the perpendicular angle from there, you know, that like where's the shoulder, where's the stress happening? It's going to be perpendicular to that. Or I shouldn't say perpendicular. I'm just imagining from the floor, go perpendicular from the floor to see like what part of the joint is getting the load, basically. And do you have control of that load? So I would have to see, like, either you can demonstrate it for me, or
So
like I would have to see a student doing it.
I have students shift forward so shoulders are over fingertips before they lower to Chaturanga. Always. And if they don't, they've got to repeat it again. I never want the shoulders back. So in my classes, they're always going to be shifted forward because I know that then you lower down to perfect angle for Chaturanga and up dog. That being said, so assuming they're in that position, they're shifted forward and they haven't understood, don't dump, and they're dumping and they're feeling shoulder pain. What are they feeling? What is it? The rotator cuff?
Biceps tendon.
Biceps tendon. Okay. Okay. I never would have thought that.
Well, you will when we scrub it.
Yeah. Okay.
Here's the biceps tendon. This is it right here. So it's hard to see on this image, but we're looking at right here. This is the forward facing part of the humerus. Okay, forward facing part. Your biceps tendon goes in the groove between the greater and lesser tubercle of the humerus, goes into the groove. And this, what you're seeing right here, we have other images of it. This one here makes it look like a big Band-Aid. This is the tendon sheath. Okay, tendon sheath. So this one looks really small. This one over here looks really big, but that's what you're looking at. It's a tendon sheath. So here's your biceps brachii muscle. Here, the tendon goes under that sheath. It's right in the front of the humerus. So it is taking the stress. And even if you do Chaturanga properly, it's still a lot of stress. The more you use your hands, the more you fire up your hands, make sure your hands are strongly active, then it evens out, like it helps to distribute the tension so it's not all in one place. That's the important thing for people to understand. So, you know, that's the danger you have in dumping. If there's some place is going to take the tension. If you don't have activation right from the fingertips, then it's probably going to be that point, because it's, you know, it's in that position, right? Perpendicular to the floor. And that's where everything's dumping down into that point. Now it's still like you can be in a more advantageous position, a more mechanically advantageous position, like you're trying to get your students there. They can really super activate their hands. They do everything correctly, but it's still a lot of tension.
Yes.
And compression, because what's happening just because of the joint position, this tendon and sheath, just even the sheath, is going to be very compressed. And the tendon doesn't like that.
So the pain is going to be on the front of the shoulder right here.
Yeah.
That's
Let's all find this now, okay? So I want you to find it on your shoulder. Like you're going to find, like there's some bumps on your shoulder, okay? Let's go to the outside. So remember we were on our acromion, this thing here. Let's go out, and then we should drop off just a little bit. Now you're on the humerus, okay? And if you were to move your arm, you would say, okay, yeah, I can feel that bone is moving, but this part here is not moving. So that means you're on this bone now. Okay, so let's drop on to there. So now you're in the right location. That under your fingers right here is called your greater tubercle, okay? If you keep moving in,
I can't get in there.
well, the greater tubercle is a ball kind of thing. Then you're going to move in, okay, toward the center of your body, and you will find there, okay, that kind of drops off. That now you're into soft tissue, and you should be in this tissue, because if you keep going, you're going to get to the lesser tubercle. Okay, so if you're here, now you might, I think it works better if you move down just a little bit, and then you should be able to scrub across, and I would recommend scrubbing across this whole area until you really know where all these things are. That will make it a little more obvious. You should be able to push that tendon from side to side. Can you feel a tendon? It's quite a stringy tendon, okay? And if you move down with it, you'll probably be able to stay with it for a bit. It gets, yeah, it stays really stringy, yeah? You guys feeling that? And then if you were to bring your arm behind you and go into Chaturanga position and follow that back up to the front of the shoulder and scrub across it, you might find that, oh, actually, that's pretty tender. You guys feeling it? You see where I am?
Yeah.
I'll stop sharing my screen for a sec. See? Okay, so I was here. I moved in a little bit. Here. And then scrubbing across. I mean, it might not be all that tender, but it's usually pretty tender, especially when you're doing Chaturanga. So that's good to be aware of. Like I say, even if you are, even if you're doing Chaturanga properly, it's still a lot of stress. That's why I recommend, you know, really using your hands, because that changes how much stress. Thank you. It changes how much stress, you know, is in that one spot. Now, what are the other things that could be an issue? Okay. We have also a bursa. So we'll look at these and what it might look like if they are irritated or damaged. Okay, so there's bursas. This bursa could be various sizes. We have bursas all over the place in our body. Wherever there's like tendons moving across bones, you'll often find bursas. These are like little membranous sacs of synovial fluid, same kind of fluid that you have in your joints, in your synovial joints. And then you've got usually if this the acromioclavicular joint, or the that's the acromioclavicular joint, or the actually, how would I say that? Acromiocoracoid joint. These usually are injured in a blow. They're not usually injured in yoga. Okay. Now, that doesn't mean to say that somebody couldn't like have a bad fall or a car accident or something and show up in yoga with that injury, or they maybe had it a long time ago and it still gives them some trouble, that kind of thing. But this is not typically something you would injure in yoga. You sometimes see bursitis. You often see rotator cuff issues and the biceps tendon, tendonitis.
When do you know it's a rotator cuff issue, and what in yoga is going to cause an injury to the rotator cuff?
Basically like pushing the arm into positions it's not ready for. Like you need to make the shoulder joint strong before you try dragging it into ranges of motion. So things like binds, if you're not really ready for a bind and you force yourself into a bind, you would be, often this is the position you're in. That's going to put a lot of stress on the rotator cuff tendon, also could be putting stress on the biceps tendon. Oftentimes people will have bursitis from a repetitive strain issue. People who do a lot of abduction or overhead movement, can sometimes get bursitis, and that will be exquisitely tender as well every time they put their arm in a certain position. It's not as typical a yoga injury.
Is it the internal rotation aspect of binds that are injurious to the rotator cuff? Because it's an internal rotation to bind and then lengthen?
Yeah.
Yeah.
Yeah, because a bind, like out here, this is not going to be a problem for the shoulder joint at all.
It's
but it's pushing, it's into internal rotation and kind of extreme extension, right? The arm going behind is an extension.
Okay.
So I've always I'm not like totally against doing the binds, but I like to make sure people are actually ready for it. And even if I can easily go into a bind, I'm still going to activate in the bind. And I'm activating in the same direction I always activate, which is externally. So I'm like pulling my arms apart this way. I don't generally, you can without having, like if your arm is in the air, okay, it's not attached to the floor, put it in and actively bring yourself into internal rotation, no problem. You can put your hand on the ground with your shoulder joint in internal rotation, push into the floor, no problem. If you're going to lift your body away from the floor, hand on the ground, then I would activate externally, because you're going to activate more muscles that stabilize the scapula. And I want to stabilize my scapula if I'm going to move, challenge my shoulder joint. So I have a feeling that there's a question in there. You're wondering about something.
I'm just trying to understand, like, based on what my students will come and complain to me about, whether they did it in yoga or out yoga, and I don't know. I just tell them, move in a way that, organize and activate, yes, but staying away from anything that causes the pain. So I don't know where, now I understand where the biceps tendon issue is. Where am I feeling something if my rotator cuff is injured? Like, what am I feeling where?
There are like tests you can do. So it's I find with the biceps tendon, I would look more at like, when do they have pain? And like say it, I can't do Chaturanga anymore. This is like too painful, or I feel weak when I do it, like something like that. You could also get in there and feel that, exactly where the biceps tendon is, have them do it if you like. But with the supraspinatus, I'll stop sharing for a sec. Well, no, I want to show you the image here. With this rotator cuff tendon, you can do, you know, it's the muscle that initiates this abduction. And it's also active, slightly active in forward flexion, but the orthopedic test for it is the empty can test. So you would go like thumb down, arm straight out ahead of you and to the side slightly. Okay, so yeah, slightly to the side. Put your other hand up against it and then push up. And if that feels like, oh, that's a positive sign. There are other tests, but that's just a very common one.
I'm sorry to ask so many questions. I'm just like,
That's great.
this is just really important to me.
Mhm.
So when that, so if I have a rotator cuff is bothering me, what do I want to stay away from in yoga, and what can I do in yoga that's going to help maybe strengthen it?
Yeah. Well, I mean, okay, we'll go to a different image. This one. Okay, so over here, you can see kind of how all these structures fit together. You've got the bursa under the acromion. You can see your biceps tendon right here. Here's the other biceps tendon, because it's two-headed, right? This is the one, though, that we run into trouble with usually, is this biceps tendon that goes into the head of the humerus. Now, the biceps tendon, look, you can tell in this, this image right here. Here's the rotator cuff tear, that's supraspinatus. And look at how close it is to the biceps tendon. The biceps tendon, actually, I'll show you in a little video here in a sec, actually attaches to the labrum. So this is another site that I wanted to talk to you about, is the labrum of the shoulder. But you can see how it is very hard. Like, that's why they have to do arthroscopic analysis or assessment, because look, rotator cuff tendon flows into the joint capsule. That's also what the biceps tendon does, flows into the joint capsule. They're both kind of at the top or forward on the humerus. And, you can have the bursa impingement, or just like impingement of the acromion on that tendon. So impingement syndrome usually means you've got an inflamed bursa. You may or may not have an inflamed tendon, but it's, these structures are coming up against the acromion, this acromion process, which is part of the scapula. And, you're getting that pinching sensation. So we have solutions to these. So we'll talk about solutions in a sec. We're just going to focus on like what the problems could be right now. But they're all in a very similar location, Dina. So I don't want you to have put pressure on yourself to figure that out, because a lot of times, they're going to need like investigative surgery to figure it out.
Oh, I would never. No,
Okay.
as a former lawyer, I'm not making a diagnosis. I
Oh,
just
no,
want to.
no, I don't mean that even, but don't put
Yeah.
pressure on yourself to know, like, because it's not always, even when you do the tests, it's not always obvious, and it's not always going to give you the information you're looking for. So that, I just wanted to show you that. Now, let's go back to this. And if you're very squeamish, then feel free to step out for a sec.
Well, I want to show you. Can't go.
Oh, just hang on. We have to watch an ad first. And it has to be about stuck poop. Okay. What? Okay, wait a second. Something. Here we go. What? Okay, this is what I want.
So I want to show you something
Here we
really
go.
cool that we recently did with the shoulder joint, and that is open up the joint capsule. You can see how amazing the head of the humerus is with some cartilage on top, and even this socket portion, which we call the glenoid cavity. So you can see definitely how the shoulder is a ball and socket joint. Now, on this glenoid cavity, or I should say the extension of it, there's a little bit of a fibrocartilage extension. Maybe you've heard of people tearing the labrum before, and that's what I'm probing here right at the tip of the probe. The labrum, again, fibrocartilage. And what this does is it extends the actual cavity or the socket to make it just a little bit more deep. So you get a little bit more surface area and more connection between the ball and the actual socket.
Okay. let's go about here.
Here, right at the tip of the probe. The labrum, again, fibrocartilage. And what this does is it extends the actual cavity.
So I think what we're seeing here is just part, probably supraspinatus. And then if you look at, let me see if I can grab it. No. There. This is probably, I don't know, this could be biceps tendon actually. But this is, I just wanted to show you, yeah, it's probably biceps tendon. And then the tendons of the rotator cuff are what you see wrapping around here that have all been cut. So here's the labrum. This is that extension I was mentioning that, you know, the very shallow socket gets a little bit of extension, sort of suctions the head of the humerus into that socket. And then you have the biceps tendon actually attaches right into it. So people can tear the biceps tendon and damage the labrum. You see, so if you have like a biceps tendon, that this would be an acute injury. It generally would not be an overuse injury. Getting pain and inflammation and irritation and weakness would be overuse, a result of overuse. But usually you would need to have some kind of a blow, like a fall or something like that, something that happens quickly to actually break this. But oftentimes when the biceps tendon gets injured in that way, then you would also injure the labrum. I'm pretty sure I did this. So to myself. So the labrum is something they're probably not going to do surgery on this unless you're like a throwing athlete or something like that. And they say that just like any other sort of cartilaginous structure, that it doesn't heal, like you will often have that told to you, but you can actually function just fine as long as you know how to use your shoulder joint and maintain it. So just so you know, like you can have these injuries and function just fine. Does anybody want to ask a question about what you're seeing here? Want to go back to the start? This is the back of the shoulder. Looks like, no, this is probably the underside. I would say this is probably subscapularis here. Kind of hard because he doesn't like hold still so I can see a bigger picture. Yeah, and there's the head of the humerus. You can see like the socket here is super shallow, but the head is nice and round. This is, yeah, the cartilage, you know, like if he taps it with a metal instrument, it just sounds like thunk, thunk, thunk.
Denise,
Yeah.
I've got a torn labrum in my hip, and I was told that the caps are a different size on both my hips. Do you get the same issues with shoulders? Do the caps, can they be different measurements?
Oh, yeah. Yeah. Everybody has its own little, you're going to have all the same equipment, but it's all like different, shapes and sizes and qualities and all of that. They're like, the thing is though, your body is like all its joints are perfect for it in that, you're not going to have like, unless you have like some really severe deformity or something, you say somebody with a shallow joint socket is going to have, more soft tissue to fill that in, or, you know what I mean? You're going to have like things that make up for it. It's just knowing your own body well enough to know, like, this sort of thing is when I get into trouble, when I push it like this or what have you, and maybe you've had injuries related to having a shallow socket. Usually that comes with more range of motion, right? And just being way more flexible.
That's what I was going to say. Yeah. I mean,
yeah.
I think I did yoga for many, many, many years. And then that guy that does the yin yoga, on his DVD, he was talking about people that can take their arms in certain positions. Are they going to look different from somebody who can't get their arms beyond this height? And I think once you realize that, no, but that's why you realize everybody's different in yoga, and nobody's going to necessarily with this. I mean, I had students for 21 years and they never got any further. So you're working with what you've got.
Oh, I see what you're saying.
Hmm.
Well, well, what does it mean to go further? Like just further into more range of motion?
Yeah. But that, you know, you look at people when they're doing down dog, and they all aspire to have a perfect V. Well, if their shoulders and their caps are obviously not as shallow, I would assume it'd be more shallow.
Well,
Cap.
you see that much more in the hip joint, like the actual socket would restrict range of motion. Like nobody's going to have, well, you know, can't really say nobody, but it'd be extremely rare for somebody to have like so much depth to their shoulder socket, like the bony socket, that it would limit their range of motion. Almost always with the shoulder, you lose range of motion because you haven't been using it. And you lose strength because you haven't been loading it. You know, that's just how it is. So I think we want to move on. So we looked at some of these typical issues with the shoulder joint. Here's kind of what it looks like. Again, some of these images, it's very hard to find an ideal image where they actually show things more like they would appear in real life. But this is the location of, you see, it says torn rotator cuff tendons, but this is really only the supraspinatus tendon. The other rotator cuff tendons would carry on behind, like toward behind this one. And this is subscapularis, which I said is much more rare, unlikely in yoga, but I wouldn't say it's impossible. And biceps tendon we often see, and then we do see shoulder impingement. Now there's a very common reason for that, and we will look at that in a sec. We're going to look at the arm lines first of all, okay? So these are the fascial lines, and remember, fascial lines have muscles within them. So you want to think of the muscles within the fascial lines as sort of the sausage in the sausage casing, okay? And if the sausage, you know, the sausage meat was contractile, that would be a lot like our muscles, right? Because if the meat inside the sausage pulled, it would take the casing with it, sort of thing. So what our muscles do is tension the fascial lines. And the reason this works to stabilize the joints is because these are continuities that go across joints. So let's look at the arm lines for a second. Let's go to the superficial side first. So this is sort of like our muscle images too, right? Where we were looking at one side is superficial and the other side is deep. So we have the same thing going on here. So at the superficial side, when we look at fascial arm lines, we have pectoralis major is part of the front superficial arm line. And then if you go down behind your biceps brachii and brachialis, this is the intramuscular septum. So that goes right along the bone and then goes down into the forearm flexors. So that's on the hairless side of the forearm, okay? So that's the anterior part of the arm, is the part that doesn't have hair. Okay, so that's that superficial front arm line. And so you've got the pec muscle crosses the shoulder joint, and then you've got the intramuscular septum coming down into the forearm flexors that crosses the elbow joint. Those come down into the palm and fingers, so that's crossing the wrist joint and the finger joints. So you're crossing all of these joints. So this continuity, when you press into the finger pads and energize like you're dialing out, you are affecting all of the joints right into the core of the body. Okay, so your pec major, we'll go to the other side. Now we'll go to the deep side. Here's pec minor, okay, lies underneath the pec major. And these are, now we're looking at the biceps brachii. It's kind of weird that the superficial line does not include biceps brachii. It includes the intramuscular septum, and the deep one includes biceps brachii, but that's why I kind of put them together in the front lines and the back lines. And that's really all you need to think about when you're looking at this. So it includes the thumb on this deep front arm line. So if you're just thinking about like front arm lines go from palm of the hand and the thumb, the forearms, the biceps, the pecs, the deep and superficial pec and the deep pec, into the core of the body, into the trunk, and also through lats in the back. So we've got, we have the hands connected to the core. Okay. Absolutely connected. So let's look at the next image, which is the back side. So the arm lines on the back are connected from the pinky side. We have, again, another intramuscular septum. These are the tricep muscles. They go back into the rotator cuff muscles. Okay. And then to the rhomboids. And I believe up here we have, this is levator scapula. I don't have that listed. This is levator scapula because it elevates the scapula. Okay. And then also we looked at trapezius. So that's the superficial layer, the deltoids, and the forearm extensors. So the hairy side of your arm. So this is the back side, the hairy side. Okay, goes across the upper back. Hopefully our backs are not too hairy, and right straight across. So from arm to arm and then into the core of the body. So interestingly, as I said, the latissimus dorsi is actually considered part of the front arm lines, but that's because it attaches to the front side of the humerus bone. And so you've got like a big triangular muscle on the back, big triangular muscle on the front, pecs, all of these feeding into the arms. So these muscles are moving the arms, but we're also using them to stabilize. Now, not all of them are external rotators. It's really the deep ones, the ones that wrap around the shoulder socket. So those are really important. And, they also fire up the muscles that stabilize the scapula. So, this is the thing why it's so important to do these little experiential exercises with your students, especially when you're teaching them organization and activation for the first time, because they'll realize right away, if they plant their hands and internally activate, they're going to use neck muscles to do that. If they plant their hands and externally rotate, now I'm using the muscles around my scapula. You can feel like the muscles around your shoulder blades are now stabilizing your shoulder and your shoulder blades onto the thorax. So that's why that, does create a nice stable joint from which to move. Okay, so now I'm going to just move this down here. You guys know this stuff really well. So here's some of the muscles that externally rotate the shoulder joint. And again, we are doing an activation. We're not talking about movement, right? So middle and rear deltoid, infraspinatus, teres minor. And then the muscles that stabilize the scapula are the trapezius, the rhomboid, serratus anterior, levator scapula, triceps long head, and pec minor. So all of those muscles stabilizing the scapula. And that's what you're feeling when you're using organization and activation. And this image is just about, starting with a mechanically advantageous position and then moving into more difficult, more challenging positions. And then I wanted to show you this one because you will see this when you get to see more of the, get into the arm lines in the fascial lines, but this might be useful to you as well, Dina. So here I'm talking about, and I talk about it in earlier lessons too. So this is toward the end. So I'm kind of assuming you've had some exposure to it already, but I know you may not have had that yet. So common patterns and relationships between postural and phasic muscles. So remember, postural muscles are the ones that have to be on way more than any other muscle because they're more responsible for holding you upright. The phasic muscles tend to be strong muscles. Of course, they can get really weak if you're not using them, but they are meant for stronger, bigger movements. So it's very common to see this sort of cross body sort of dysfunction. Even when you're trying to change it, like, if you're going to be sitting at a desk for hours, you're going to fall into these patterns, like you're just going to. So you want to, practice with your body as much as you can, so you mitigate any kind of holding yourself in those positions permanently. So here, let's just sort of, let's tease this out a bit. So when we're looking at deep neck flexors, so deep ones, in your lower pecs, so down in the lower pecs, your neck flexors are actually part of your deep front line. Don't worry if you haven't been there yet. Your lower pectorals are part of your functional lines. So again, don't worry if you haven't been there yet, but they're also part of your arm lines. Okay. Your pectorals, your lower pecs especially, are phasic muscles. So that means they're going to be kind of lazy, but they're powerful. They can be powerful. Again, it's use it or lose it, but they just are not wired to be constantly turned on. Okay. Now on the other side of the body, your upper traps, which are part of the back arm line, and your levator scapula, which again, those neck muscles, those are wiry, hyperactive postural muscles. So that's why so many people have a habit of pulling the shoulders up, because those are muscles that elevate the scapula and the shoulder girdle. So people will habitually do that. You see people like when they're cold, you see people when they're driving, you see people on their phones, like a lot of people elevate the shoulder girdle. They're using those neck muscles. So then they go into asana practice, and then they're doing it there too, right? So you're trying to teach them, okay, now is the time to use our scapular muscles. We stabilize the scapula on the thorax and stabilize the head of the humerus in the socket with organization and activation. Let's move down a little bit into, again, some of the postural muscles here, okay, are the sternocleidomastoid, these muscles on either side of the neck that come down to the clavicles and first rib. And the upper part of the pectorals, okay, so upper pecs are postural, lower pecs are phasic. Interesting. Pec minor, that nasty little one underneath that likes to pull the scapula forward, that's also a postural muscle. So again, they're wiry and hyperactive. Anterior delt can be like that too, and biceps brachii. So again, these muscles, they work a lot, right? We're always reaching forward. We're reaching, these muscles are very busy muscles. Now, counter to that, on the other side, you're going to have phasic, powerful potentially, but lazy muscles that don't kick on unless they have to. So that will be your rear deltoids, which are part of the back arm lines, the mid and lower traps. Okay, so that's why people elevate the scapula. The upper traps are postural, wiry, and hyperactive, but the mid and lower ones that stabilize the scapula are more phasic and lazy. So again, that's why you have to develop a pattern of getting them to turn on. Rhomboids, which are between the shoulder blades, those are part of the back arm lines. They're also considered phasic and lazy. And then the serratus anterior, which is part of the spiral lines, but also potentially lazy. A lot of people have no serratus anterior. I mean, that's why they have winging scapula, and they're quite weak that way. And that also affects their chaturanga a lot. You know how you want to stabilize the scapula on the back? Well, if you don't have serratus anterior to be nice and strong, then you're really going to struggle keeping your scapula stable.
I do something, and maybe I'm doing this wrong. I do an exercise to help develop serratus anterior, and I want to know what you think of it. So you would be in up dog, or you could be in floating up dog, and I call floating up dog, you're just on the balls of your feet. Because some people just don't like to press on the tops of the feet.
Oh, okay, sure. You've got your toes tucked, you mean?
Yeah. So I give them the option. So on an inhale, we take up dog. And then on an exhale, we press and round the spine. The body stays straight. And I am under the impression that that is going to help develop serratus anterior, because that's what I was told by another yogi in my family.
Okay, so I want to make sure I understand. So when you
Yeah.
say up dog, spine is in extension, it's not
Yeah.
neutral.
No, your spine is in extension. So here's the up dog. I'm doing it standing. I'm in up dog, right? And then I'm going to press into the tops of my feet, assuming my tops of my feet are down. And on an exhale, I'm going to pull my chest in. Like think of pubic bone to breastbone, really, and just kind of hollow body. And it's very hard to do like
Yeah.
repetitions of this. And where I feel it, it's right in here.
Mhm.
And I would hold that for the exhale, inhale, come through. And people really fatigue quite quickly if they're not strong there. And the other thing, and that's all preparation really for a posture like Lolasana. So I would do Lolasana, you know,
Can I just
Lolasana.
think about this for a sec?
Yes, yes, yes.
Because I do a very similar thing, but the angle is different. So like I do hollow body, but also like scapular, like, I don't know, I call it threading, where you're on the level, and you can do this like for people who aren't quite as strong, you can like in table pose, you can do like, see, I'm retracting my
Yeah.
scapula.
Yeah, it's the same thing.
Yeah.
That's a modified version.
But I think, are you here? Or no, you're here. Yeah. Yeah, I think that's pretty good angle. I think that's pretty
Yeah.
good.
And then the
Yeah.
other would be Lolasana prep. So, you know Lolasana?
I can't imagine it right now.
Unfortunately, I'm not strong enough right now at this point to demonstrate it, but you would be balancing, hands are down, you're in a tucked position, knees to chest, feet to glutes, and you're holding that perpendicular to the floor.
It's
So-
not crane pose.
No, you're
Okay.
just holding with your abs, your knees to your chest, and you're
Oh, okay.
So your
Yeah.
scapula, I'm your serratus anterior way turned on, and then the prep for that, I have hands on blocks, body shifted forward, tops of the feet on the ground, and on an exhale, pulling the knees to the chest, like compression being really important. Compression, and then perhaps lifting one foot to the glute, hold, and then put it down other side. So in my mind, I'm training serratus anterior. I hope that that's and abs too, but
Yeah. Oh, for sure.
yeah.
Yeah, that's a lot of abs.
It's a lot. Do you
yeah.
see why some people don't like to come to me?
I would love it.
Oh, they're like, no, she's too hard. But yeah.
Okay. Well, yeah, I mean, that sounds good. Like,
Okay.
again, it sounds like I would say a bit advanced,
But
but
yeah, but I would do it in tabletop, like you're saying,
Yeah.
and I would start in tabletop. But some of my
Yeah.
classes now, that's we need to do it in upward dog.
Yeah.
Okay.
But that is, yeah, you would definitely recruit serratus anterior.
Okay. Great.
Yeah, and I mean, when you're doing any kind of arm balance, then you need rear deltoid, the traps, the rhomboids, the serratus, like they're all going to have to participate. So yeah.
Okay.
So those are basically very powerful pushing actions that are also like isometric. So you know, again, like you're not stacking joints for alignment. You have to be super active. It's more of an isometric contraction that you're doing in an inversion. You know what I'm saying, right? So those are going to call into action these muscles that would prefer to be lazy until they have to absolutely get to work. So, but like if we don't recruit them, then they will be lazy, and that will become a problem for us. So anyways, I did this because I wanted you to see that, like, with head forward posture, especially like if we're collapsing forward, we've got like some kind of lazy muscles here and hyperactive ones back there. And then we've got like hyperactive muscles here and lazy muscles back there. So that's why it's so easy for us to fall into those postures, and why we have to like activate to, do something different than just collapse. Okay, so I wanted to draw your attention to something extremely important for shoulders. So if you guys are trying to think about like, what are ways to, what's something I can bring to my students to make sure, like even outside of yoga, they're doing something that's really beneficial to the shoulders. So hanging, right? You guys, I'm sure, have all heard about like how important hanging is for the shoulders. And there's different ways of doing it. Like, you know, you could just have a chin-up bar at home, or, you know, I don't know if you have an option to go to the park, or maybe you go to a facility that has bars or rings or something that you can play on. You know, I would say do some hanging, do some pulling up if you possibly can. What we do in yoga tends to be pushing actions. This is why I love using a strap and doing pulling whenever possible. That also gets, you know, latissimus dorsi and some of our other pulling muscles involved. So using a strap and like, you know, doing isometric contractions, you know, like with a strap at different levels, you know, in different ranges. I highly recommend, because pulling is just really important. And also, like, you know, while you're doing a pulling action in class, just letting your students know how important that is, so that they might clue into next time, you know, they're at a park or a playground or something like that, or maybe in their house. How much would you love having one of these apparatus in your house? I would love to have that. That would be so much fun, with some rings. We want to
I
have.
love, my husband hates it, but in my house, I have
Oh,
a ring set up for my kids.
oh,
So they can hang and swing and do whatever. It's on like the Jolly Jumper.
oh yeah.
It used to be the Jolly Jumper, but now
Yep.
it's for hanging and swinging.
Cool. That's awesome. Yeah, I love that idea. Especially for boys. Well, not especially for boys, but boys really need like stuff to throw themselves at constantly. All right, so that's cool. So let's do we want to like review any of this? How are we feeling?
Can I ask a question, please?
Please, yeah.
Just in relation to hanging, when you hang off something, is that passive?
No.
Because it feels to me like when you hang and just your whole body weight is you know, it's gravity is just bringing you down. Obviously, yeah, your hands are holding, but I kind of feel like it feels like a stretch under the arm, like a really intense stretch. But I don't know how. I mean, obviously, if you're trying to pull yourself up, that would be active. But
actually, this is a really good question, Jane. So
okay.
I'm going to throw down the gauntlet here.
Okay.
Is that the right way to say that? Like hang for a minute and then we'll talk.
Okay.
Set a
Okay, I'll
timer,
do that.
set a timer and hang for a minute. You actually have to activate like mad. And here's the thing, like this will show you evidence of the law of irradiation. Okay, I do this a lot. Most of you heard me do this, but maybe Jane hasn't. So Jane, I want you to make a fist for me. Okay, now squeeze the fist and tell me what muscles, you don't have to name them specifically, but where are you activating muscles when you squeeze your fist like that?
Oh yeah, I can feel it actually right up my arm.
Right up your arm. Okay, squeeze it harder. Make your elbow straight and squeeze harder.
Yeah.
Okay, now is it going up a little further? Okay,
yeah,
now squeeze
5%.
as hard as you can. Like squeeze as hard as you possibly can.
Okay, I'm feeling in the shoulder and the back of the scapula.
There, okay. So that's what it's like to hang.
Okay.
You're gonna have to tighten your grip and fight for your grip. And when you are gripping, this is why fingers and toes, feet and hands need to be active during asana, because you want, in order to activate this chain, this kinetic chain, or the fascial lines, you have to have the whole thing active. If hands and feet are floppy, you're not going to be able to secure the shoulder. You're not going to be able to secure the hip. And then I'll give you another little challenge, since you're going to be there for a whole minute. Draw the shoulder blades down a little bit, like pull your shoulder socket into your body, and you'll see you're really going to activate all those muscles that control the scapula. And yeah, it's going to be very illuminating. So I would love to hear what you think. You're going to learn a lot just from doing that. So I would challenge everybody to do
It's
that.
a standard conditioning for a gymnast. We used to have to
Yeah.
just hang. It would be a contest at the end of like workout, and everyone's just hanging, and the last person to drop off would be the winner. It's really important.
Yes.
Okay.
I love it.
Great.
I love it.
Can I
Yeah.
ask a question?
Please.
I'm being confused by, generally yoga teachers, you often hear their cue to draw down the shoulder blades. But then I have heard from several teachers not to do that, because it's kind of against the anatomy, because if you lift the arm, the shoulder blade needs to rotate and slide up.
I know
So
that to me just,
and then working against it might actually cause impingement. Is it so
Okay.
or not? This
Well,
is like, I don't get this
okay,
clear in my
this
head.
will straighten it out for you, Bianca.
Yeah.
It's a great question. Okay, let's once again look at our bones. Okay, and we looked at how when we raise the arm to the side, we have to, this joint is going to move, right? This is so okay. The sternoclavicular joints, right? Okay, so you've got your breastbone here, your clavicle is attached to it. You lifting the arm, the clavicle is going to move up. Now the clavicle is angled up like this. Do you think your shoulder blade is going to stay right there? No, right? Your shoulder blade is also going to move up. That's called upward rotation. So if your arms are overhead, your shoulder blade, if you didn't move your shoulder blade, your arm would only, like if you keep your scapula totally stable, your arm, this shoulder joint is only going to be able to move, I don't know, around 30, 35 degrees, something like that. If you let it go, if you want to move it more than that, the shoulder blade will have to upwardly rotate. The clavicle is going to lift, the shoulder blade will upwardly rotate. Now, the reason we just talked about when we looked at the muscle, like how hyperactive trapezius and levator scapula, these neck muscles are very hyperactive, right? They're attached to your scapula. They pull your scapula upward. Okay. Now, if you have hyperactive, overly strong upper neck muscles or neck muscles, upper back neck muscles, and these ones are weak, then you're gonna lift your shoulder girdle up, like you're going to lift your arms by using your neck muscles is basically what people do. And the reason why they say to draw your shoulder blades down is because they're trying to solve that problem. They're trying to help you stop activating these hyperactive muscles and lift your arm via, the deltoids and the supraspinatus and the muscles of the scapula, that actually move the shoulder joint, right? Instead of lifting the whole shoulder girdle, you want to lift, you want to let the arm flex or abduct or whatever, right? So if the better way to come at it is by being aware of some activation around the shoulders, like being able to fully move your shoulders without lifting the shoulder girdle. Okay, so there's no way, if your arms are here, there's no way you can prevent the shoulder blades from moving, but we do, as best we can, want to prevent like over recruiting the neck muscles all the time, which is a pattern that we really do see in so many people. Like, that's why they're doing this in Chaturanga and whatnot, right? They're always elevating the scapula and the shoulder girdle instead of using those muscles around the scapula to stabilize. So, people like, I don't know, it's just such a nonsensical argument in a way,
Well,
but it's trying to solve a problem.
I just noticed that when I was trying to, because I always cue to depress the shoulders and get out of the neck, but
Yeah.
also I just tried to create a core to hand or hand to core connection when my shoulders are elevated without them being on the floor, and I cannot do it.
Mm-hmm.
I feel like I can't really access the arm lines
No.
when I'm elevating, but when I depress my shoulders, not too much, I pull into, now I feel arm lines, I feel everything.
Yes.
But I
Yeah.
cannot do it when they're elevated. Although you could do it when they have to be elevated, when you're upside down, the shoulders are elevated, when you're inverted. And
Yeah.
then you can have that connection, but not when you're standing up. So always upright, the shoulders should be depressed. I think that's what
Well, the thing is, like, this is always the problem between the position and the activation, right? So they're going to elevate and upwardly rotate a little, but we just don't want them to overdo that. So we want to use the muscles that depress the scapula. We want them turned on. So we're not just using neck muscles. So, I'm agreeing with exactly what you said, but I'm just saying, like, this is the argument, because they aren't making a distinction between the movement, which is elevation and upward rotation, and the activation, which are muscles that are actually trying to restrain that position to some degree, just in order to stabilize the joints. Yeah, which is what we're doing. Like, again, like if we have our hands planted and we're dialing out, we're not doing that. We're not trying to make this, we're using the muscles that make this movement happen, but it's not going to happen because our hands are grounded. Now you're completely open chain, you're moving your shoulder girdle around, you can move it into disadvantageous positions. You can disconnect your shoulder girdle from the rest of your body. But, again, like, it's just an argument that I think confuses a lot of yoga teachers. And it's partly just because they're not making a distinction between the movement that's happening and the activation that would actually stabilize that position in a more advantageous, connected kind of a way. So, but it's a good question to ask, and I'm glad it came up.
Yeah, thanks, that made it clear.
Good. All right. Super. Yeah. So, like, it's a cue that's kind of fallen out of favor. And for a while there, people were enjoying themselves arguing with each other about it on Facebook and stuff. But now it's sort of like, it's like, our cues are always meant to help people get into the best possible position. And, sometimes, they're like, I heard this one argument, like, technically, when you inhale, your diaphragm is descending. So technically, because of its attachment to the spine, it's going to compress the spine a little bit when you're inhaling. But what we often say, inhale and like extend the spine, right? Or get taller. So we could have an argument, well, that's not even possible, because when the diaphragm descends, then, the spine gets compressed. So, that doesn't make sense. But in how you experience your body, it does make sense. It makes great sense, because it's that resistance that you're feeling, that you're tugging up against, that does make you feel taller. So, again, like, once you kind of, relax about how much anatomy you actually know, and have felt all of these experiences in your body, then you won't waste your time arguing about this stuff. Yeah. Anybody else with a question or a controversy, maybe? Was this helpful? Okay, cool.
Is it possible to have access to this slide presentation?
Of course.
Where
It's
would I find
always where we post the call,
calls? Okay,
anything that I used in the call is going to be attached.
okay.
Always, every single time. Except for last time, because I want to develop those ideas a little bit more, where we talked about how much to charge and stuff like that. Yeah, I want to develop that a little bit more and probably do like a little presentation on that. So, but if you want the document, I'm happy to give it to you as well. So, yeah. Okay. Well, I did the bulk of the talking today, sadly. So how's everyone doing? Jane, I wanted to know if that woman who called you, did she show up for yoga when that she stopped and wrote down your number and off the blackboard?